Thank you very much. Thanks for the invitation. It's really a pleasure to be here in Barcelona. And I'm afraid I'll have to submit you to some statistics on Friday afternoon. That's not easy, but I will try to keep it really applied and easy. I don't know how this works. Oh, it's at the other side. No, that doesn't work. Is there a knob that I'm supposed to touch or? Oh, forward here. See, statisticians are not very good with machines. Forward. Okay, yes, I see. Okay, thank you. Thank you. We need clinicians. Okay, so a few warnings first. I'm not going to talk about GI cancer, I'm afraid. And I do this purposely. Not that there are no issues to discuss in GI cancer, but I thought that it would be better to take my examples from breast cancer and lung cancer, simply because that way you will be less biased by what you already know. So I hope to have kind of an interactive session, and so be on your guard, because towards the end of my talk I will ask questions from you, and I hope to have kind of a vote, a raised hands vote. The other thing that's important to mention is that I will not talk much about statistics, and this is because I think Friday afternoon doesn't lean itself well to statistics. So I will talk more about concepts in general. So let me get started on sort of basics about clinical trials. What is a clinical trial? There are really four key aspects in a clinical trial. A trial is a prospective experiment which tests one or more treatments, so that's the first key aspect, in specific populations of patients, second aspect, using an appropriate design, the statistical design, which is my specialty, and using clinically meaningful endpoints. So I'm going to sort of look at these four aspects of clinical trials and try and discuss how these things change really fast. And I think we live in a very exciting time because every principle of clinical trials is put to the test today. And I think it's fair to say that we will have to invent new methods for clinical trials in the coming years. So it's very exciting and very challenging at the same time to be doing clinical trials today. Now we have new paradigms in clinical trials, and these new paradigms have an impact on every one of these four aspects of clinical trials. Treatments change fast. I don't have to tell you this. The arsenal of new treatments is increasing by the day, and we now have new modes of action of these treatments. We don't have just cytotoxic drugs anymore. We now have targeted drugs. We have immunotherapies. And these drugs have substantially different modes of action. Targeted therapies work on subsets of patients. Immunotherapies may have delayed long-term effects. And so all of these aspects have an impact on how we design trials. As far as patients, we now have a lot more knowledge about the molecular biology of tumors, which allows us to, in many cases, select patients for trials, or perhaps stratify trials by the patient characteristics, so as to try and define which patients respond to the treatment and which patients don't. And whether it be in breast, lung, or GI cancer, there are a number of known molecular aberrations that predict the effect of treatment. There are many more to come, including some that may be based on the next generation sequencing techniques that were so far too expensive but are now within reach financially and can probably be used to good effect to select patients for trial, or will be so in a few years. As far as endpoints, I think we've been almost obsessive about improving survival of cancer patients, and that has worked well. The survival of patients has increased over time substantially, and this is largely due to better treatments. But I think now, with survival being prolonged, probably beyond what anybody would want to wait in a clinical trial, we will have to find new endpoints. We will have to focus on biomarkers. We will have to focus on surrogate endpoints that predict in the short run what the clinical outcome in the long run of these patients will be. And we have some biomarkers, but not many. I think this is one of the areas where in oncology we will have to put the most effort, is to find new endpoints based on biomarkers. And biomarkers can be really a lot of things. They can be based on molecular targets. They can be based on things you can measure in the blood, like circulating tumor cells, circulating tumor DNA. We've just seen, that imaging techniques are moving fast forward, and I think these techniques should be used far more in clinical trials than they are, at the moment. And so maybe in the future we will have these very complex biomarkers that we can look at in clinical trials and that allow us to predict the clinical outcomes that the patients may expect to see far later. And finally, in terms of statistical design, we have a lot of new designs that are emerging, and you may have heard about some of them, the biomarker-driven designs, platform trials, basket trials, master protocols, adaptive designs, Bayesian designs. The list is long, and I'm sure many of you are awed and puzzled by all these new names, and I'm sure that you wish to know more about these designs. At least I know I wish to know more about these designs because they can be quite complicated and not immediately obvious. So what I'm going to do is to take two examples, one from breast cancer, one from lung cancer, and try to illustrate the kinds of new designs that are appearing today and that, in my opinion, will revolutionize the way we do clinical trials. And I'm going to try and show that not all of these new designs are in fact good. Some of them are pretty good and probably will stay with us. And some of them, I think, can be criticized for various reasons, and I will try to show how and why. So the first trial is an example of a phase 2 trial, which is so-called Bayesian adaptive design, and it's called I-SPY 2. I mean, I live in the US, and you know, in the US you can't open any oncology journal, you know, without having something about I-SPY 2. It's really all over the place. And so people who do not know what I-SPY 2 trial is and how it was designed really wonder, you know, is this trial as good as some claim, or does it have its problems? And that's what I'm going to address here. So the trial is shown here, and be careful, this is not a randomized trial between the top line and the bottom line. The top line is patients who have an HER2 amplification, which, as you know, is important in breast cancer and requires treatment by trastuzumab or some other anti-HER2 drug. And the bottom line is patients who don't have a HER2 amplification. And so what you see is that the patients, depending on whether they are amplified or not, will go to the top or the bottom line. They will receive conventional treatment, which is paclitaxel followed by AC, plus or minus trastuzumab. And then they will also receive up to 6 new drugs, A, B, C, D, and E. And actually that's 5, A, B, C, D, E, yes, 5. Actually that's 6. But anyway, a lot of new drugs are being tested in this protocol. Then after this treatment, patients will go to surgery, and at surgery, they will be, the endpoint will be assessed, and the endpoint is pathological complete response at the time of surgery. What you see on this graph as well is that depending on the outcome of the patients at surgery, the trial is adapted, and I will describe later what that means. The adaptation consists of putting more patients on the treatments that appear to be better than the others. So you try to sort of edge your trial towards the better doing treatments based on PCR rates so far. Okay, so let's look at the 4 cornerstones of this clinical trial: the treatments, the patients, the endpoints, and the design. The treatments. We have a standard treatment, and then in a non-randomized fashion, some experimental treatments are added, and as you can see here, there are in fact 6 such new treatments. Patients. These are patients with operable breast cancer, and they are in fact defined in terms of 10 signatures. So each patient has 1 signature, which is based on their hormonal receptor status, HER2 amplification, and then a non-conventional gene signature called MammaPrint, and that's a gene expression profile based on 70 genes. And MammaPrint is actually not used in clinical practice, but it's used in this trial to define the profile of the patient to receive certain treatments. What about the endpoints? As I said, the primary endpoint is PCR, pathological complete response, and there are a number of other endpoints: the MRI functional tumor volume, the residual cancer burden, and then RFS and OS. So the conventional endpoints are at the bottom of this list, almost as if they were sort of secondary endpoints that no one really cares about. And then finally, the design, as I said, it's an adaptive Bayesian design. The randomization is adaptive, and the Bayesian design means that before the trial is started, there is already some idea as to which drugs work and which don't. And that's captured in what we call a prior distribution for the treatment effect. All right, so that's the I-SPY 2. Remember this one. And now we move to the other trial that I'd like to use as an example. It's a so-called master protocol phase 2 trial. and it's in lung cancer, it's in small cell lung cancer. It's called the Lung Map trial. And as you see here, patients are with squamous cell lung cancer are actually have their tumor analyzed. And so based on the sample, based on the tumor sample, they go into one of 4 sub-studies. And so depending on where they fall, they will be randomized between a conventional treatment, which is the same in all treatment groups. So in all sub-studies, the control group is the same. Okay, it's conventional chemotherapy versus a new drug. And so the only sort of peculiarity of this trial is that instead of having control versus new treatment, you have 4 sub-studies in which for each of them there is control versus new treatment comparison. But the new treatment now depends on what sub-study the patient is put on, and that depends on their molecular characteristics. And as you see here, the molecular characteristics are some gene mutations or gene amplifications or some gene fusions. So it's really based on the peculiarities of the patient that they go into one of the 4 sub-studies. Treatments, just like in the I-SPY 2 trial, we have a standard group, a standard treatment, docetaxel, and we have 4 experimental groups. But the big difference between this trial and the previous one is now we randomize between the conventional treatment, docetaxel, and the new treatment. In terms of patients, these are patients with squamous cell lung cancer, and they, as I said, they have some molecular aberration that allows the trial to sort of channel the patients to the sub-study that they belong to. Endpoints, well, in this particular trial, the endpoints are conventional PFS, progression-free survival, and OS, overall survival, so conventional endpoints. And in terms of design, except for the fact that the patients are stratified and go into the sub-studies, this is a randomized design. So even though these 2 trials are innovative, they are very, very different. Now let's compare the 2 trials, and here is where I'm going to ask you some questions. Treatments, both trials have in common that they use standard chemotherapy plus or minus targeted agents. So the originality of both trials is that, in fact, you need to involve several drug companies. It's no longer a company trial, a Roche trial or an Amgen trial or a Sanofi trial or whatever. It's, in fact, a trial that combines drugs from several sponsors. And this, I think, is the way to go. It's obvious that when we target drugs at specific patients, we can't screen 1,000 patients to find the 5 or 10 patients that have the molecular aberration that the new drug targets. We need to do this in a single protocol and then channel the patients where they belong. So both trials have that in common. But there the comparison stops. In terms of the patients, the Lung Map trial selects patients based on established predictive factors. The I-SPY 2 trial uses signatures based on both genetic aberrations that are well known, but also the MAMA print, which is still an experimental predictor. In terms of endpoints, as I said, Lung Map uses very standard endpoints. I-SPY 2 uses PCR and other exploratory endpoints. And so here's my first question. If you had to enter a trial like this in colorectal cancer, for example, which of these endpoints would you favor? Would you favor a very short time endpoint such as PCR, or would you favor a long-term established endpoints such as PFS? So who would prefer to use PCR, pathological complete response? You could do this in colorectal cancer, for example. Okay. And who would favor the PFS? Oh, wow. Okay, well, PFS wins. Now, why is that? PCR is an endpoint that has the big advantage of being observed very reliably at the time of surgery, which is early in the course of the disease. The problem of PCR is that it is not shown, it hasn't been shown, to be a good surrogate for long-term endpoints. And so the whole I-SPY 2 trial is premised on the principle that if you can improve the pathological complete response rate, you will also improve survival and progression-free survival, or in this case, disease-free survival. Now, is that so? Well, the FDA actually did a very interesting meta-analysis, which is shown here and published in The Lancet, where they took 12 randomized trials, 12,000 patients, so a large data set. And what they tried to do in that data set was to validate pathological complete response as a surrogate for DFS and OS in early breast cancer. And so what they showed was this. Indeed, pathological complete response is associated with better disease-free survival. You see that the red curve here is patients who had a PCR, and the blue curve is patients who did not get a PCR. And obviously, PCR is a very strong prognostic factor. The hazard ratio is 0.5. So patients who have a PCR are about twice less likely to get a disease recurrence than patients who got a PCR, who didn't get a PCR. So it's a very strong prognostic factor. But if you take that same data set and now look at the correlation between the effects of the treatments that were tested in these 12 randomized trials, if you look at the effect of these treatments on PCR, which is the horizontal axis, correlated with the effect of the same treatments on DFS, which is the vertical axis, what you see here is a complete lack of correlation. So that means if you can improve PCR in a trial, it's fine. I mean, you have a better response rate in that trial, but that doesn't predict for a better effect of the drug on event-free survival or disease-free survival, or the same is true of overall survival as well. So in other words, PCR is just not a reliable surrogate. You can actually increase the PCR without an increase in DFS. And so for people who are worried about what are the clinical benefits of these treatments, and certainly the payers and the regulators are, it's not just because you've improved the pathological complete response rate that you will also have a clinical benefit for the patients who were so treated. And so, in fact, this is a real concern. And that concern was actually, in a sense, confirmed by two trials, the NEO-ALTO and the ALTO trial. The NEO-ALTO trial was a trial that looked at a comparison between 3 drugs in the neoadjuvant setting, also in breast cancer. And what you see here is the response rates in patients, both hormonal receptor positive and hormonal receptor negative. What you see here is the response rate, the pathological complete response rate to 3 drugs, trastuzumab, lapatinib, and the combination of the two, so 3 treatment groups. Obviously, the combination did much better than either drug alone. And so based on this, you would say, well, good, I've increased the PCR by giving the combination of trastuzumab and lapatinib. So surely I will also see a benefit in terms of disease-free survival. And in fact, you do, if you're very optimistic, because these curves are not exactly superimposable. But I think it's fair to say that people who care for reimbursing drugs won't be terribly impressed by the difference between the curves. And this is disease-free survival. For survival, the difference is even smaller. So I think the problem is that, yes, the benefit in terms of PCR was very poorly predictive of a benefit on the long-term endpoints that really matter for these patients. And so to design a phase 2 trial based on an endpoint that doesn't predict well is a huge danger. We are at a danger of picking drugs and testing these drugs when in fact they will not provide long-term benefits. So another key aspect and another key difference between these two trials is the design. As I said, the I-SPY 2 trial is Bayesian adaptive. And I mean, that sounds exciting, doesn't it? It's really nice to know that we can use Bayesian techniques, it makes our life better or easier, and we can adapt the randomization in a manner that I will show in a moment. I mean, surely that's better than just simply randomizing. I know clinicians hate randomization. And I do too. I mean, it's never pleasant to have to flip a coin to decide something. But oftentimes that's the best you can do because you just don't know. So the difference between an adaptive randomization, which is used in I-SPY 2, and the regular randomization, which is used in LungMap, is that in the adaptive randomization, what you do is to flip a coin which is biased. Instead of having a 50-50 chance of having the new treatment or the control, what you do now is you flip a coin and you put more patients on the treatment that so far has been doing better. If I give an example here, suppose that at the moment where you enter a new patient, you have 6 out of 11 responses in the treatment group versus 2 out of 7 in the control. 6 out of 11 is better than 2 out of 7. So you're going to favor treatment. You're going to give a higher probability for the next patient to receive the treatment. So you will allocate treatment with 80% probability and control with 20% probability. Now that sounds apparently very nice because you sort of favored treatment that does better rather than the other one. But the question is, do you actually know that the treatment is better, or does it just happen that so far it seems to be better, but in a non-statistically confirmed manner? So the randomization that I show on the right is the sort of usual randomization where you randomize 1-to-1, 50% chance of either treatment, but as we know, you can also use an unequal randomization and flip a coin that has a 2/3 chance of giving the new treatment versus 1/3 chance of giving the control. So you can bias the coin in favor of the treatment if you wish, and I think that's often a very good idea, by the way, but that's a fixed ratio. You don't change that ratio. You always give more chance for a patient to receive treatment than control. That doesn't depend on the observed outcome, and that's a crucial difference. Why is it a crucial difference? Well, for sort of hard to explain reasons, but if you don't take my word for it, you have literature that shows this. So if you had to choose between an adaptive design and a fixed ratio design, who would favor the adaptive design? I mean, you may say so. I mean, I don't like it, but yes, some people like it. Okay, good. And who favors the sort of fixed ratio, 1-to-1? Okay, and who favors the fixed ratio 2-to-1, if I may ask? Yeah, so I think we have sort of a divide audience. Some of you prefer 1-to-1, some of you prefer 2-to-1. We can discuss that. That's a minor issue, but the big issue is the difference between the adaptive randomization and the fixed ratio randomization. Now, if you have a need for mathematical reading, perhaps at night before you fall asleep, this is a very good paper. It will put you asleep for sure. It's actually a paper on why adaptive designs are always statistically suboptimal. So whenever you hear the word adaptive design, I'm not saying that they are always bad, but that means you have to pay a price for being adaptive, and the price is that these trials always lose power compared to fixed designs. So this paper is kind of fundamental because it shows that when we choose to be adaptive, we know that we are theoretically not as good as we could be if we simply used a fixed allocation ratio or whatever other adaptation is being made. If you want to read something that's more readable than the paper I just showed, here is a paper in Journal of Clinical Oncology, which I think is a very good paper on why adaptive randomization is not desirable. And as you see here, these authors recommend the use of a fixed 2-to-1 ratio instead of an outcome adaptive randomization. So clearly, if you are interested, you can look at this paper, and I think that's a very good summary of the arguments for and against adaptive randomization. But there has been a sort of debate recently more about the ethics of randomization, and some people have actually written that outcome adaptive allocation trials are in fact not ethical. So this is a paper that you can look at if you believe that that's the case. I was one of the discussants of this paper, and I think that is not true. I don't think that ethics has anything to do with this. What we're talking about is a method of treatment allocation, and it's absolutely unrelated to ethical considerations, in my opinion. But anyway, that's another issue that some people have raised. Is it ethical to tell a patient, look, we will adapt the randomization so that you will get the better treatment in probability? We can't guarantee that you will get the better treatment, but on average, you should get the better treatment. Now, how should I feel as a patient if I'm told that I will get the better treatment and by bad luck I get the other one? Because there's still a chance that I'm randomized and I get the other treatment. I must feel very bad then. And so I think that's the ethical crux of the argument there. I don't think that adaptive randomization makes that argument any more easy. Actually, it makes it more difficult. So finally, if we now had to design a trial in GI cancers, and we wanted to do a sort of innovative trial design, maybe a master protocol, maybe a Bayesian adaptive design, and this is kind of a survey to see if my talk was successful or not, who would design the trial as the I-SPY 2, who would design it as lung map? So who would favor an I-SPY 2 trial in GI? No one. Oh boy, I was more successful than I thought. And who would design the trial as lung map? Okay, a few people. All right, so lung map wins. I'm delighted that it does, because I think that shows, in a sense, that we can do innovative trials without, in fact, relinquishing anything that we've done so far. We can randomize patients, we can select patients, we can do a PFS-based trial, we can actually do all of the good things that have served us so well so far, and adapt the trial design to the new sort of treatments that we have available and the new selection of patients we have available. We don't have to do Bayesian adaptive designs to be smarter than in the past. And for those of you who, again, want to read more about this, I apologize, this is a bit of a self-serving advertisement, but I just published a book with Richard Simon at the NIH and Shigeyuki Matsui in Japan. And when I started working on this book with these other two guys, I thought that this book would actually have a lot of answers to these challenges that we now face, how to design new trials. And I must confess I'm extremely disappointed that the book raises a lot of issues, but actually offers very, very few solutions. So I think 5 years from now, 10 years from now, if I'm still around, we will have another talk, maybe on this stage, and maybe we will have better answers than today. Thank you very much.